Okay, so welcome everyone to the step one lecture by Dr. Haidari for CVS. This is lecture number 7. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Yes, okay, good. So while we wait for the other students to come and join, it's already been more than 10 to 15 minutes. Can we do a couple of questions from Amboss, yes or no? Yes? Okay, good. Just give me 1 second. Okay, so today we're going to do questions from CVS pathology from Amboss. And give me 1 quick second. Excuse me. Okay, so can you guys see my screen? Yes or no? Yes. Okay. So how much time do we get for each question? As I speak, we will get 1 minute and 30 seconds. Okay, so we will get 1 minute and 30 seconds for each question. And after 1 minute and 30 seconds, I am going to move on to the next question, and that's how we are going to solve this. Are we clear, everyone? Yes or no? Yes. Okay, good. So is everyone ready? Is everyone ready? Yes or no? Okay, so I'm going to mute myself and then let's begin. Okay, is anyone facing any difficulties understanding the questions? Yes or no? Are you guys seeing the questions properly? Is anyone having any difficulty understanding the question? Oh, let's begin. Okay, for this one, do you guys want to hear the auscultation sounds? Yes or no? Okay, let me see if you guys can hear them. Let me know if you can hear them or not, okay? Did you guys understand the auscultation sounds? No? Okay, so we'll skip this question. No. So we'll skip that question. Let's move forward to the next question.
I would probably not be a teacher.
Can you guys hear my voice? Yes or no? Yes. Okay, just give me 1 second. Okay, how about now? Can you guys hear my voice now? Okay. 1 second. Can you guys see my screen properly? Yes or no? Okay, good. Now, let's begin with the first question. Oh, okay, now, so let's begin. This first question, as you guys can see over here, this first question, can you guys hear my voice clearly one more time, please? Can I get a yes in the chat box? Okay, good. So the first question is over here, which of the following is the most likely cause of this finding? So what do we have? A 52-year-old man comes for a routine health examination. He has not seen a physician. He works as a telemarketer. Dull pitched, low, uh, the sound is loudest at the left lateral decubitus and during end expiration. It shows the dull, low pitched sound during late diastole. Which one of this is the correct answer, please? Fast answers, please. Okay, so we have one student, Dr. Ellen, that said A. Everyone's an A. Low pitched sound during late diastole that works, that is heard best at the apex. Very good. This is left ventricular hypertrophy. So over here, a dull, low pitched sound during late diastole is which sound are they trying to describe over here? Which sound are they trying to describe? They are trying to describe it. S4, right? Okay, good. And if someone is at the left lateral decubitus position, wouldn't this allow the S4 to hear more clearly? Yes or no? Yes. Okay, so next time we hear, we see something like this, where we see that we have a sound that is accentuated when the patient is moved at the left lateral decubitus position, we will think about S4, okay? So that's that. In atrial septal defect, what type of sound do we get? We get splitting heart sound. In dilatation of both ventricles, we will not have any problems with S4, because over here, S4 is for stiff ventricles, okay? This is for dilated ventricles. Fusion of the mitral valves is for mitral stenosis, where we will get diastolic murmur. Okay, we will get a diastolic murmur in mitral stenosis. And over here, this sound will not be low pitched. Are we clear? This sound will not be low pitched. Okay, is everyone clear? Yes or no? Can we move on to the next question, please? Which of the following is the most likely initial step in the pathogenesis of this patient's coronary condition? Which one did you guys choose? Crushing substernal chest pain, diaphoretic, ECG shows ST elevation, coronary angiogram shows 80% stenosis. This is Which of the following is likely initial step? Very good. This is the first initial step is the first step of Verco's triad. You guys remember Verco's triad? For example, if someone has a block of the coronary arteries over here, what is the likely cause of the coronary artery block? Is it an atherosclerosis? Yes or no? Fast answers, please. The answer is yes. So over here, what are the first steps for the formation of atherosclerosis? We have three reasons. Number one, endothelial injury. Number two, stasis. And number three is hypercoagulability. Okay, let's move forward. Which of the following is the most likely underlying cause of these autopsy findings? Which one did you guys choose for over here? Which one did you guys choose for over here? Everyone? Okay, look. After the patient got diagnosed with adenocarcinoma of the colon, examination shows vegetations. The vegetations are loosely attached and can be easily scraped off. Microscopic examination shows that it's composed of interwoven fibrin strands with mononuclear cells. Interwoven fibrin strands with mononuclear cells are your composition of a non-bacterial endocarditis. Are we clear? Non-bacterial. If it was bacterial endocarditis, then we will not have, right? If it was a bacterial endocarditis, then we will not have these sort of fibrins and mononuclear cells. What we will have is we would have inflammation and neutrophils. Yes or no? Neutrophilic infiltrations, not mononuclear infiltrations, and we will have bacterial colonizations. Are we clear? Yes or no? Okay. Now, if someone has an adenocarcinoma of the colon, then always remember they are in a state of hypercoagulability. So when they are in a state of hypercoagulability, then there's a possibility then they can have cholesterol emboli. And at the end of the day, when we do a microscopic examination, if there's a bacterial colonization, would it not show the presence of bacteria in the colon? Yes or no? I mean, in the vegetations, yes or no? When we do a microscopic examination of the vegetations, would it show bacteria or not? Yes or no? Fast answers, please. In bacterial endocarditis. The answer is yes. So over here, in microscopic examination, do you guys see anywhere that says that there's a bacterial colonization? The answer is no. It says interwoven strands with mononuclear cells, which represents lymphocytic infiltration over cholesterol emboli, which resulted in fibrosis. Are we clear? Yes or no? Okay. So next time, how do we not make the same mistake? Can anyone tell me? Next time, when we see a patient of colonic carcinoma and bacterial endocarditis, we need to see in a microscopic examination if bacteria comes up or not. If bacteria doesn't come up, then what is the common cause of endocarditis in adenocarcinoma of the colon? Fast answers, please. Bacterial or non-bacterial endocarditis? Fast answers. The answer is non-bacterial. Thank you so much. Okay, let's move forward. Which of the following sets of changes is most likely to occur when the patient stands up? Which one did you guys choose? Very good. Okay. A, orthostatic hypotension. The answer is A. So venous return will decrease, carotid sinus baroreceptor activity will decrease, and cerebral blood flow will decrease. Okay. Let's move on to the next one. Which of the following is the underlying cause of the patient's ventricular hypertrophy? Fast answers, please. Accumulation of sarcomeres in parallel. Very good. This is very good. This is left ventricular hypertrophy. As why? If a patient has hypertension, do they have increased afterload? Yes or no? Do they have increased afterload? The answer is yes. If they have increased afterload, when the left ventricle is pushing against that increased afterload, will they increase in number? The answer is yes. There would be hypertrophy. If the hypertrophy is in a series right? If the hypertrophy is in series, would we call this dilated hypertrophy or will we call this concentric or um, concentric hypertrophy or as in a serial hypertrophy, like the one we see in dilated cardiomyopathy? We will call this what type of hypertrophy? We will call this concentric hypertrophy. Are we clear? Yes or no? Because sarcomere proteins are added in two ways. One is they're added in a serial pattern. Another one is that they're added in a parallel pattern. If they're added in a serial pattern, in which sort of diseases do we see serial pattern addition of sarcomere protein? Can anyone tell me? Which type of diseases do we see serial pattern addition of sarcomere proteins? Can anyone tell me very quickly? Nope. How about, very good, dilated cardiomyopathy? Dilated. Okay. Next one. Okay, we skipped out on this one because you guys could not hear the sound. So what happened was a 56-year-old man comes to the physician for increasing shortness of breath. His blood pressure is 145/90. Cardiac examination is shown. Let me show you the cardiac examination. Can you guys hear the sound by any chance? Can you guys hear the sound? No? Okay, please listen to the sound and let me know what you guys think. Please listen to the sound. Okay, have you guys heard the sound? Yes or no? Okay, so what do you guys think? What do you guys think is wrong with this patient? Very good. This is a left ventricular failure. Yes. S3. This is an S3 sound. S3 sounds as an atrial knock. Yes or no? That over here, you have a sudden rush of blood that's going from the left atrium to the left ventricle. When does a sudden rush of blood goes from the left atrium to the left ventricle? When the left ventricle is not contracting. Yes or no? When the left ventricle does not contract, does it have a lot of space to accumulate for a lot of blood? Fast answers, please. The answer is yes. So can the blood rush easily from the left atrium to the left ventricle? The answer is yes. Okay. So that's it. Over here, what did you guys choose? Which one of the following is the most likely cause of the patient's findings? Which one did you guys choose? Everyone? Very good. This is a patient of left ventricular failure. Okay, do you see how big or basically how enlarged the left ventricle compartment is compared to the other chambers? Yes or no? The answer is yes. That's because this shows that there is left ventricular failure. As a result, patients have developed pulmonary edema, as simple as that. Okay. Tricuspid regurgitation. This is how tricuspid regurgitation would look like. Doesn't this look like this part is enhanced? Yes or no? This part is enlarged. in tricuspid regurgitation? Yes, okay, this is how the tricuspid regurgitation would look like, because this would show that the right side of the heart is enlarged. That's that. Let's look at the next one. This is how spontaneous pneumothorax would look like. Do you see how in spontaneous pneumothorax, you have the lungs basically pressing on the heart? Yes or no? This shows that the heart is constricted. That's that. And another thing is, do you see the pulmonary infiltrates? Yes. This is the lung that is collapsed. This is the lung that is collapsed, and this is the air. Do you guys know how spontaneous pneumothorax, or what spontaneous pneumothorax is? When the lung collapses, either due to trauma or due to any other reason, there is air that accumulates in the cavity, and this pushes on the lungs, and this results in lung collapse. And do you see that the trachea is deviated to the left? Look, the trachea is deviated to the left. Okay. Next one. This is acute respiratory distress syndrome, where you see ground glass opacity of the lungs. Then this is pulmonary embolism, right? This is pulmonary embolism, where you see this over here, that you see the wedge. Okay. This is the wedge, which shows the infarct, right? This sign is known as Hampton sign. I'll talk about this in details. And over here, you see that there is a little bit of dilatation of the pulmonary artery, which shows that there is the difficulty in getting the blood out to the lungs, right? So that's that. Okay, what else? This is pulmonary emphysema, where you can see where you see that the lung fill, right, is very dark, which shows that there's air trapping. That's number one. Number two is you see that the diaphragm is flat, right? Flat diaphragm, and then air trapping inside the lungs, and this is pressing on the heart. That's pulmonary emphysema. This is interstitial pneumonia, where you can see lung infiltrates, right? Lung infiltrations. This is bronchial asthma, the same as emphysema almost, which shows air trapping, right? Which shows air trapping. And since it's a female, we cannot appreciate the diaphragms as much, but this should give you an idea that this is an air trapping that's happening over here. Okay. And this is the last one, that is idiopathic pulmonary fibrosis, where once again, you see that the chest X-ray looks like this. Is there a possibility? Do you see the tracheal deviation, which also shows that this patient might have some sort of a collapse? Yes or no? Right? So that's it. Next one is, which of the following is the most likely cause of the patient's current condition? Which one did you guys choose? Very good. Which of the following is the likely cause of infant cyanosis? Which one did you guys choose? Okay, 6 hours after birth, he was delivered. Physical examination shows increased work. X-ray chest shows no abnormality. Echo shows elevated pulmonary artery pressure. He started on medication that increases the smooth muscle CGMB, and there's improvement in his tachypnea and oxygenation. Which one of this is the correct answer? This is persistent pulmonary hypertension of newborn. Okay, so let me tell you what this is. So basically, persistent pulmonary hypertension of newborn is something that we will study in pulmonology, right? But over here, in persistent pulmonary hypertension, what happens is that patients, they usually have an extremely high resistance in the pulmonary circulation, right? They have an extremely high resistance in the pulmonary circulation. So what happens is these patients, when they are given a drug such as nitric oxide, And when they're given a drug such as nitric oxide, and that decreases the smooth muscle contraction and it initiates smooth muscle vasodilatation, smooth muscle dilatation, then this decreases the resistance in the pulmonary circulation, and this allows the blood to easily flow from the right side of the heart to the lungs. So over here, this is different from ductus arteriosus, because over here, if we had ductus arteriosus, right, then they will not have improvement of the sign symptoms with this drug that relaxes the smooth muscle. Have I made myself clear? If they had a ductus arteriosus like problem, then either they would benefit from NSAIDs, or if they had any sort of cyanotic disease, then we would like to give prostaglandin to keep the ducts open. So neither in the question did they mention NSAID or prostaglandin. So over here, since they have the sign symptoms which are getting better after the patient has been described a dilator, this diagnosis is the diagnosis of persistent pulmonary hypertension. So if the question is, which of the following is the most likely cause of this infant cyanosis? So what happens in persistent pulmonary hypertension, right? In persistent pulmonary hypertension, we give a drug that basically causes smooth muscle dilatation, but at the same time, that drug contains nitric oxide, and nitric oxide has the ability of converting converting ferric to ferrous, that is Fe2 plus to Fe3 plus. Now, the problem is when ferric is converted to ferrous, can it carry the oxygen? Yes or no? The answer is no. So this is a very difficult question. I need you guys to understand this question very easily. Okay. Let me tell you what's happening. A patient came to you with sign symptoms of pulmonary arterial hypertension. They were given a drug. So these are the constellation of events that happened in the question. Patient came to you with pulmonary arterial hypertension. You gave a drug that causes nitric oxide release, and nitric oxide release causes dilatation. So after you gave the drug, the patient's sign symptoms decreased, but later the patient became hypoxic. The question is, what is the reason for the hypoxia? The reason for the hypoxia is, first and foremost, this patient has a disease of persistent pulmonary hypertension. When you gave nitric oxide, this related in dilatation. When this related in dilatation of the pulmonary arteries, this allowed the blood to flow from the right side of the heart to the lungs. But also what happened is, when the blood flew from the right side of the heart to the lungs, the nitric oxide converted the Fe2 to Fe3. And when it did that, the hemoglobins, they were not able to carry enough oxygen. So oxygen carrying capacity decreased. As a result, the patient became hypoxic. Are we clear now? Do you understand how difficult this question is? Ferrous to ferric, my apologies. Okay. Are we clear? Yes. Okay. Next one. Which one did you guys choose? Which one did you guys choose for this one? Okay, this is not right. This is not your over here. This is due to, okay, so look what happens. First and foremost, does this patient have a venous block or an arterial block in the legs? Fast answers, please. Does this patient have a venous block or an arterial block? Venous, right? What would happen if the patient had an arterial block instead of a venous block? If the patient had an arterial block instead of a venous block in the legs, wouldn't the sign symptoms be the sign symptoms of claudication? Yes or no? That is, the patients will have low blood supply, numbness, cold temperature. I mean, the feet will be cold, and the patient would have loss of hair, right? And there would be extreme amount of pain when the patient would want to walk. Since the patient have a venous ulcer, or I mean a venous block, there is only dilatation, edema, and what else? Dilatation, edema, and congestion. As a result, this is your venous status or venous ulcer. Okay, let's move on to the next one. Which one did you guys choose for over here? Very good. Let's move forward. That was WPW syndrome. Which one did you guys choose for over here? D and anyone else? Is there anyone else who chose another answer? Very good. Congratulations. Let's move forward. This is viridans streptococci. Yes or no? Is this viridans? The answer is yes. Okay. So viridans is gram-positive, catalase negative cocci, right? So that's it. Which one did you guys choose over here? Okay. So this is basically an elderly woman who comes with worsening shortness of breath and swelling of the legs. Crackles are heard, and we hear a low-pitched early diastolic sound in the left fifth intercostal space that becomes louder in the left lateral decubitus position. In the left lateral decubitus position at end expiration. Which of the following is the most likely cause? So you guys thought that this one sounds very similar to your S4. Yes or no? This one sounds very similar to this. Low pitch sound during late diastole that is heard. The sound is loudest at the left lateral decubitus position and during end expiration. Over here, you have a low pitched early diastolic sound. Do you see what the difference is? Do you see what the difference is? What is the difference? The difference is, just give me 1 second. Okay, can you guys see my screen? My apologies. Now, so we were talking about the difference. What was the difference that we were talking about with S3 and S4? The S3 difference is that we have a murmur. Right? What sort of murmur do we hear for S3? That's the thing that I wanted to talk about. The type of murmur that we see for S3, please write this down in your book. Okay, please write this down in your book that we have a murmur that is a low-pitched, early. The word is early, diastolic murmur. Diastolic murmur. This is for S3. Another one is low-pitched, late diastolic murmur. Late diastolic murmur. This is for S3 or S4? Fast answers, please. This is for S4. So are we going to make the same mistake again in the future? Yes or no? Yes. What happens during diastole? What happens during diastole? During diastole, does the ventricle relax? Yes. Does the ventricle relax? Yes. So when the ventricle relaxes, the blood starts moving from over here to over here, right? If we hear a sound, an early diastolic sound, this shows rushing. And we know that sudden rush of blood is S3. And if there's a late sound, over here during diastole, this represents S4. Okay. Are we clear? Yes or no? Guys, I need to make sure that you understood this. Are we going to make the mistake again in the future or not? Yes or no? Okay, which one did you guys choose over here? Which of the following is the most likely cause of the patient's symptoms? Which one did you choose? This is E. Very good. Do you remember yesterday I told you that one of the highest yield causes of pericarditis is a viral infection? Yes. If there is 4 to 5 options, which one would you choose? Number one for an acute onset of pericarditis. This is viral, right? So that's exactly what it is. Next one over here. Which one did you choose? Very good. Okay. This shows increased portal hypertension. Okay. So if there's a carcinoma of the colon, right? Which of the following describes the route of the spread? So as a rule of thumb, right? If anything we have in the intestines, right? Anything in the intestines, if they have to get absorbed by the blood, do they directly reach the systemic circulation? Yes or no? The answer is no. First of all, whenever anything is absorbed from the intestines, where do they go first for filtration or removal of toxins and other substances? Do they go to the liver? The answer is yes. Okay. After the liver says it's okay, right? After the liver says it's okay to remove the blood. I mean, after the liver says it's okay for the blood to reach the systemic circulation, then they reach the systemic circulation from the liver. Is that why when we drink a lot of alcohol or when we drink a lot of different types of substances that is harmful for our body, that those substances, they get absorbed from the intestines and they go to the liver first and then they reach the systemic circulation? Is this why during drinking alcohol, the liver gets affected the most? Yes or no? The answer is yes, because the liver has to be the first responder to check whether the blood is okay to reach the systemic circulation or not. So that's that. So over here, first and foremost, they'll go from the superior rectal vein to the inferior mesenteric vein, then to the hepatic portal vein. Okay, so that's that. Are we clear, everyone? Yes or no? Okay, good. So from what it sounds like, that we have a couple of physicians who are actively participating in the class. Okay, so those physicians are Dr. Ellen, Dr. Itar, Dr. Fidel, Dr. Jorge, Dr. VK, Dr. Tasneem. Okay, and thank you so much, Dr. S. Thank you so much for actively participating. The rest of the students who are not participating as much, did you guys understand the questions or not? Yes or no? Yes? Okay. So how did you guys do? Did anyone get 6 right out of 15? 6 or more out of 15? Yes or no? Dr. VK is 9. Dr. Ether is 12. Dr. Ellen is 11. Very good. Who else? Dr. Tasneem is 8. Very good. Dr. Hagar is 8. Very good. Thank you so much. Okay, so you guys are doing really well. Really proud of you guys. Okay, so with that being said, today we are going to start cardiovascular pharmacology. Is everyone ready? Yes or no? No. So let's begin. So today we're going to start talking about cardiovascular pharmacology. And today in the pharmacology lecture, we're going to talk about the different sorts of drugs that we use. We're going to try to make sure if we can finish the segment by today. If not, then we might extend tomorrow. Not sure, but I'll try my best. So with that being said, let's begin. First and foremost, we are going to start talking about the treatment for hypertension. Okay, we're going to start talking about the treatment for hypertension. Just give me 1 second. The treatment for hypertension that we are going to start talking about, we will talk about what choices of drugs we have for different sorts of hypertensions. And over here, the number one, do you guys remember that there was this one time when I talked about how we have drugs that we give for different ethnicity, yes or no, and how first aid will correct that at one point? Yes, how we basically give thiazide for African Americans, and we give ACE and ARBs for Caucasians. Yes. Okay. So number one, let's start talking about this. That over here for your step one, unfortunately, the information is still the same. So as a rule of thumb, according to first aid, if you receive a question about African Americans coming to you with hypertension, then the first choice of drugs would be thiazide. And if the patient is Caucasian or Asian, then the first choice of drug that will be is ACE or ARB. So let's start talking about this. Do you guys remember this information? Yes or no? This is very widely asked in your exam. I need you guys to remember this. Okay, now let's start with the first one, that is essential hypertension. In primary hypertension, that is essential hypertension or familial hypertension, the first group of drugs is thiazide. And the ethnical group that is very highly susceptible to develop primary essential hypertension is African Americans individuals. So please remember this. After that, we can give ACE inhibitors, angiotensin receptor blockers. That's that. But this is widely asked. Which one will you give first? The answer is thiazide. Always remember when you read this, the first choice of drug is very important. So if someone comes to you with hypertension and heart failure, what is the first choice of drug that you will give for hypertension and heart failure? First of all, you will give a drug that will decrease blood volume, right? So the first choice of drug always is diuretics. So over here, do you have to remember all the names of the drugs or just the first choice of drugs? The answer is try to remember only the first choice of drugs. Are we clear? Yes or no? Okay, try to remember only the first choice of drugs, and then the rest are more or less the same. Have I made myself clear? Yes or no? Next one. In hypertension with diabetes, you will choose a drug that will not only decrease blood volume, but will also prevent filtration damage, hyperfiltration damage. So do you remember how I told you that angiotensin has angiotensin? For example, this is the glomerulus, right? And this is the afferent, and this is the efferent. Do you guys remember how I told you that angiotensin will constrict the efferent arterioles, and this will cause hyperfiltration damage in your diabetic patients? Yes, the answer is yes. So diabetic patients, they already have hyperfiltration damage. So in diabetes with blood pressure management, the first group of drugs is an ACE inhibitor, which will prevent this constriction. And as a result, the blood can easily flow. Okay, so that's that. So hypertension with diabetes mellitus, the first group of drugs is ACE or ARB. Next one is hypertension with asthma. The first group of drug is ARB. Why do we not choose ACE inhibitors? Because they can cause a dry cough, right? Do we choose beta blockers? The answer is no, because beta blockers can exacerbate an asthma. If we have to choose beta blockers for hypertension and asthma, we have to make sure that it's cardio-selective beta blockers. For example, all the beta blockers that starts from A to M, that is atenolol, bisoprolol, metoprolol, these are cardioselective beta blockers. Are we clear? Yes or no? Yes? Okay. Next one is hypertension in pregnancy. Only for hypertension in pregnancy, you need to remember all the group of drugs. All the group of drugs. That is nifedipine, methyldopa, labetalol, and hydralazine. Okay? Only for hypertension, you need to remember all the drugs. So one more time, for primary essential hypertension, which drug do we choose? For primary essential hypertension, thiazide. Very good. Next one, hypertension with heart failure. Which drug do we choose first? The answer is diuretics. Yes. Next, hypertension with diabetes. Which one do we choose first? The answer is ACE. Next one, hypertension with bronchial asthma. Which one do we choose first? We choose ARBs. And in pregnancy, which drugs do we choose? We choose nifedipine, labetalol, hydralazine, and methyldopa. Okay. Are we clear? Yes or no? Okay, good. So that's that. That's basically what it is. Now, over here, before we talk about this, okay, before we talk about this, I'll talk about how these drugs work very quickly. Just give me 1 second. Okay, just give me 1 second. Oh, okay. So basically what we're going to talk about is we're going to talk about the cardiac muscle, whether we need the cardiac muscle to contract or whether we want the this smooth muscle to relax, right? Where, for example, does the cardiac muscle have smooth muscles? Yes or no? The answer is yes. Okay. So whether we want to and also, does the blood vessels have smooth muscles? Yes or no? Does the blood vessels, they have smooth muscles? The answer is yes. So this is basically what type of a cell? This is a smooth muscle cell. Smooth muscle cells. That is the muscle that is not under our that is the muscle that is not under our control, right? This is the smooth muscle. So we can control skeletal muscles, not smooth muscles. Now, smooth muscles, they can either do two things. Either they can contract or they can relax. So Our goal and our choice of drugs will basically depend on the ability to make the smooth muscles contract or relax. So let's talk about the first thing over here. First and foremost, let's start talking about how many receptors does a smooth muscle have. So the smooth muscle shall have all types of receptor, but the first type of receptors are, let's talk about the voltage-gated calcium channels. Okay, let's talk about the voltage-gated calcium channels over here. Okay, what does calcium do? Calcium in the voltage-gated calcium channel, calcium has the tendency of entering through the voltage-gated calcium channel. Once it enters through the voltage-gated calcium channel, calcium induces more calcium release from where? Calcium induces more calcium release from the sarcoplasmic reticulum. Very good. Okay. So as a result, all of these calcium, the calcium that is entering and the calcium that is released from the sarcoplasmic reticulum, they will bind together with another peptide component, and we call that component as calmodulin. We call them as calmodulin. And calcium and calmodulin, they will bind together, right? They will become a force. And what will this force do? Let me tell you what this force will do. First and foremost, what were the two actions of the smooth muscles? Fast answers, please. The two actions of the smooth muscle was contraction and relaxation. Yes. And our choice of drug is either to make the smooth muscle contract or make the smooth muscle relax. So in order for the smooth muscle to contract, right? In order for the smooth muscle to contract, there is an activity of an enzyme, which is called myosin light chain kinase enzyme, myosin light chain kinase enzyme. For example, when the smooth muscle contracts, do we want the actin and the myosin to bind together? Yes or no? Do we want the actin and the myosin to bind together? The answer is yes. So actin and myosin will bind together in the presence of a phosphate. And kinase is a group of enzyme that allows actions to happen by adding a phosphate group. So over here, if we have actin and myosin, and if we add a phosphate group to this actin and myosin, can this start contracting? Yes or no? The answer is yes. So myosin light chain kinase will add a phosphate group to the actin and myosin, and this will lead to contraction. So vice versa, if we want to relax the muscle, if we want to relax the smooth muscle, do we give a kinase or do we give a phosphatase? Do we give a kinase or do we give a phosphatase? The answer is we would give a phosphatase, myosin light chain phosphatase. So this will relax. Now, if calcium, does calcium cause smooth muscle contraction or smooth muscle relaxation? Fast answers, please. Calcium causes smooth muscle contraction. So this calcium calmodulin complex, will it activate myosin light chain kinase or myosin light chain phosphatase? Fast answers, please. They will activate myosin light chain kinase. Very good, absolutely wonderful. So over here, if we give a drug that is a calcium channel blocker, if we give a drug that is a calcium channel blocker, can the calcium enter through the voltage-gated calcium channels? Yes or no? The answer is no. Can it cause more calcium release from the sarcoplasmic reticulum? Yes or no? The answer is no. Can there be formation of calcium calmodulin complex? No. Will there be activation of myosin light chain kinase? No. Will there be contraction? No. Will there be relaxation? Yes. Are we clear? Okay. Good. Very good. So have we understood the mechanism of action of calcium channel blockers? Fast answers, please. Yes. Okay, good. Now, let's talk about another group of drugs that will contract the smooth muscles. Let's talk about another group of drugs that will contract the smooth muscles. Are they sympathetic group of drugs or parasympathetic group of drugs? Fast answers, please. These drugs are, that will contract the smooth muscles. They are a sympathetic group of drugs. Very good. Sympathetic group of drugs. What drugs or neurotransmitters or drugs can cause smooth muscle contraction? Are they epinephrine, norepinephrine, angiotensin, vasopressin, or ADH? Yes or no? The answer is yes. How do they cause smooth muscle? How do they cause smooth muscle contraction? Okay, how do they cause smooth muscle contraction? So epinephrine, norepinephrine, angiotensin 2, and vasopressins, they activate a receptor that is the GQ receptor. This is the GQ receptor. And whenever we have activation of GQ receptor, we have activity of secondary messenger system that we call inositol triphosphate, IP3. Inositol triphosphate acts with another secondary messenger system called triacylglyceride. We call this IP3, diacylglycerol. We call this IP3 DAG system. IP3 DAG, what does this do? This stimulates the sarcoplasmic reticulum to release more calcium. When more calcium is released, will it bind with the calmodulin? Fast answers, please. The answer is yes. After that, will they activate myosin light chain kinase? The answer is yes. Will this cause contraction? The answer is yes. Okay, are we clear? Yes or no? Okay. Next one. Okay, next one. Next one is you have another activity, right? That's happening over here. This another activity that's happening over here is that let me tell you one more thing. Before you understand this, you have to understand something. Okay, you have to understand something. Are you guys aware about the alpha receptors in our body? How many alpha receptors do we have in our body? 2. Alpha 1 and alpha 2. Are you guys aware that alpha 1 is pro-sympathetic and alpha 2 is anti-sympathetic? Are you guys aware of this? Yes or no? Alpha 2 receptor, if you activate alpha 2 receptor, will there be more sympathetic activity or less sympathetic activity? Fast answers, please. There will be alpha 2 activation will result in less sympathetic activity. Okay. And the way that alpha 2 receptors, they work is that whenever they are stimulated, they act via the GS mechanism. They work via the GS mechanism. So why am I talking about this? Let me tell you why I'm talking about this. Over here, you have another receptor. Okay, over here, you have another receptor. This is the GS receptor, right? This is the GS. This is GQ. This is GS. Whenever there is GS, do we also have a GI? Yes or no? The answer is yes, right? We also have a GI receptor. Okay. Now, what's happening is over here, whenever we have activation of GS and GS, there is activation of the CAMP system. Yes or no? There is activation of the CAMP system. CAMP, cyclic adenosine monophosphate. Cyclic adenosine monophosphate. Whenever there's formation of cyclic adenosine monophosphate, how? From adenosine monophosphate. Okay, let me use the black color. 1 second. Adenosine monophosphate is converted to cyclic adenosine monophosphate. Yes. How? By the help of an enzyme, adenylate cyclase. Yes or no? Adenylate cyclase. And GS stimulates adenylate cyclase. Adenylate cyclase that is stimulated by GS will convert adenosine monophosphate to cyclic adenosine monophosphate. Now, this cyclic adenosine monophosphate, can it be converted back to adenosine monophosphate? Yes or no? The answer is yes. How? By the help of the enzyme phosphodiesterase 3. Phosphodiesterase 3. Now, if there is the formation of cyclic adenosine monophosphate, the phosphate in the cell, is it used up to form CAMP? Yes or no? The answer is yes. If the phosphate inside the cell is used up to form CAMP, will there be increased activity of the myosin light chain kinase? Yes or no? The answer is no. Why? Because the myosin light chain kinase also needs the phosphate, but that phosphate is not available. That phosphate is taken by the adenylate cyclase to form CAMP. As a result, will there be increased activity of myosin light chain kinase? Yes or no? The answer is no. So will the smooth muscle relax or will the smooth muscle contract? Fast answers, please. The smooth muscle, they will relax. Very good. Okay. So if I give a drug that is inhibiting phosphodiesterase 3, if I give a drug that's inhibiting phosphodiesterase 3, will I have more CAMP or less CAMP? Fast answers, please. I will have more CAMP. So should the vessels be relaxed or contracted or contract? The answer is the vessels should be relaxed. Relaxed. If I gave phosphodiesterase 3 inhibitor, once again, do I have more CAMP or do I have more AMP? Which one? I have more CAMP. What happens when I have more CAMP? Am I inhibiting the myosin light chain kinase? The answer is yes. As a result, will the vessels be relaxed or contracted? They will be relaxed. Have I made myself clear? So phosphodiesterase 3 inhibitor can cause smooth muscle relaxation. Okay. Are we clear? Yes or no? Okay, very clear. Let's move forward. If I give a drug that stimulates the GS, for example, what are the drugs that can stimulate GS? These are example, let's say prostaglandin, then you have prostacyclin, then we have adenosine, right? Sometimes epinephrine when it binds to the beta-2 receptor, not beta-1, beta-2 receptor. Will they activate the GS? Yes or no? The answer is yes. What happens when they activate the GS? Will it activate the adenylate cyclase? Yes or no? The answer is yes. AMP will be converted to CMP. CMP will cause relaxation. Okay. Are we clear? Okay. Good. Very good. Now, the next one is, let's talk about how we can make the best use of myosin light chain phosphatase. Myosin light chain phosphatase. Just give me 1 second, please. Okay, can you guys hear my voice? Yes or no? Yes? Okay, good. So let's talk about how we can use myosin light chain phosphatase. So I could not follow pages. Which pages are you talking about, Dr. S? Do you have any question, Dr. S? Yes or no? You could not follow PD, meaning phosphodiesterase, and PS. It's not PS, it's GS. This is a G. It's GS. Okay. The last part is that CAMP is converted to AMP by phosphodiesterase. When phosphodiesterase is not working, CAMP will inactivate myosin light chain kinase, and as a result, the blood vessels or the smooth muscles will stay more relaxed. As simple as that. Okay. Let's move forward with myosin light chain phosphatase. Now, if we activate myosin light chain phosphatase, will there be more relaxation in the smooth muscle or less relaxation in the smooth muscle? Last answers, please. There will be more relaxation. Very good. So what is a second messenger system that activates myosin light chain phosphatase? The second messenger system that activates myosin light chain phosphatase A is CGMP. CGMP is formed from GTP. My apologies. GTP. GTP stands for guanoside triphosphate. It is converted to cyclic guanoside monophosphate. Guanoside triphosphate is converted to cyclic guanoside monophosphate. And cyclic guanoside monophosphate is converted back to GTP by another enzyme, that is phosphodiesterase 5. Phosphodiesterase 5. Have I made myself clear? Yes or no? This CGMP will activate myosin light chain phosphatase. This activation of myosin light chain phosphatase, will it cause more relaxation or less relaxation? The answer is it will cause more relaxation. So if anything is activating this pathway, we are increasing vessel relaxation. Yes or no? So what is the number one group of drugs or pharmacology that will increase the activity of CGMP? The number one group of drugs is nitric oxide. Nitric oxide. This is not this is nitric oxide. Okay. Nitric oxide will cause conversion of GTP to CGMP. This will cause activation of myosin light chain phosphatase. And as a result, more smooth muscle, they will be relaxed from being contracted. Okay. Are we clear? Yes or no? Now, if we block a drug that is phosphodiesterase 5, if we block phosphodiesterase 5, can I get the attention of Dr. Ellen? If we block phosphodiesterase 5, will there be more relaxation or less relaxation?
More.
Yes, Dr. Ellen.
More.
If I block phosphodiesterase 5, can you hear my voice?
Yes, I said more relaxation.
More relaxation. Very good. If you block phosphodiesterase 5, we will get more relaxation. Dr. Hagar, you said less, so you are wrong. Why? Phosphodiesterase 5 is converting CGMP to GTP. So if you block phosphodiesterase 5, will CGMP be converted to GTP, Dr. Hagar? Yes or no? No. As a result, will we have more CGMP or more GTP? Which one? More CGMP. Very good. So should we have more relaxation or less relaxation? More relaxation. Okay. Okay, there's another high yield question. Okay, Dr. Ellen, thank you so much for your help. There's another high yield question in your USMLE step 1, right? The high yield question is, does anyone know which amino acid gives rise to nitric oxide? Which amino acid gives rise to nitric oxide? Does anyone know? Very good. The answer is arginine. Right? The answer is arginine. Where do we get arginine? Do we get arginine from the diet? Yes or no? The answer is yes or no. Where do we get arginine from? Yes. Thank you so much. We get arginine from the diet. And what happens is the arginine, it will enter the cell, L-arginine. They will enter the cell. And inside the cell, this arginine is converted to nitric oxide by nitric oxide synthase. This nitric oxide will come out from the cell and they will go to the smooth muscles. When they go to the smooth muscle, what will they do? They will cause activation of CGMP from GTP and they will cause smooth muscle relaxation. Have I made myself clear? Yes or no? Yes. Now, the next question is, if there is any drug that is increasing the activity of nitric oxide synthase, will there be more nitric oxide from arginine or less nitric oxide? More nitric oxide. As a result, will there be more dilatation or less dilatation? More dilatation. So what are the drugs that can cause increased activity of nitric oxide synthase? For example, drugs such as histamine, serotonin, then what else? Bradykinin, right? Acetylcholine. Do these drugs cause vasodilatation? The answer is yes. And this is how. Are we clear? Okay, so that's that. Now, I know you guys might have a little amount of confusion still, but we are going to keep this picture over here. If we have time after the end of the class, I'll talk about the picture. Okay, that's how they cause flushing. Yes, when there's vasodilatation, there's leakage, and also there's vasodilatation leads to a high amount of blood being present in the blood vessels, which results in flushing. Okay, are we clear? Oh, good. Now let's start talking about the drugs one by one. Okay, 1 second. Now, first of all, let's start talking about calcium channel blockers. So one more time, how does the calcium channel blocker work? Are they going to block this channel over here? Yes or no? The answer is yes. After they block, will there be less calcium entry? The answer is yes. Will less calcium bind with calcium calmodulin? The answer is yes. As a result, there will be less activity of the myosin light chain kinase, and there will be more relaxation or contraction. Fast answers, please. The answer is there will be more relaxation. Very good. Okay, so this is how the mechanism of calcium channel is. Now, there are two types of calcium channel blockers. Please underline this. One that solely works on the blood vessels. These are called dihydropyridines. Dihydropyridines. So amlodipine, nicardipine, nifedipine, nimodipine, they all work in the smooth muscle. Okay. Are we clear? Yes or no? And only two drugs, verapamil and diltiazem, these are the two drugs that only works in the heart. Non-dihydropyridine, that's the one that they work in the heart. So how do you remember which one works in the heart and which one doesn't work in the heart? Always remember that these two drugs, okay, VD, they work in the heart. And all the rest of the calcium channel blockers, they work everywhere else. Mechanism of action, I have told you how they work, so I'm not going to repeat myself. Which one is more potent in the vascular smooth muscle? The answer is amlodipine and nifedipine is more potent than diltiazem and verapamil. And in the heart, verapamil and diltiazem, they are more potent than amlodipine and nifedipine. That's it. Now, let's talk about their clinical use. That is very important. Where do we use these drugs? For example, you need to remember that we use calcium channel blockers for hypertension, angina, and in Raynaud's phenomenon. In Raynaud's phenomenon, we have peripheral vasoconstriction. As a result, what happens? As a result, we have peripheral claudication. So that's that. Okay. In clinical use, what can we use nimodipine for? Nimodipine is used for subarachnoid hemorrhage. If you can remember this, that's okay. You know what? My apologies. You need to remember this. 1 second. You need to remember this. Nimodipine is used for subarachnoid hemorrhage. Okay. How do you remember this? Do you remember the cartoon Finding Nemo? Yes. Yes or no? Nemo was a fish. Okay. Okay. Nemo the fish. Imagine Nemo the fish having a head. Can you guys hear my voice? Yes or no? Okay. I'm not really sure entirely what happened right now. But what were we talking about? We were talking about Nemo the fish. Yes or no? We were talking about Nemo the fish. Finding Nemo. So Nemo was found with a bump on the head, with a bump on his head. For Nemo got hurt on his head for the fact that Nemo deeping is used for subarachnoid hemorrhage. Okay, can we use this mnemonic to remember this information? Yes or no? Okay. Yes. Next one is if you have a car, right? Isn't it better for the car to be present in terms of urgency? For example, it's very urgent. You need to go somewhere. Are you going to walk or are you going to use your car? You're going to use your car, right? Yes or no? Yes. Okay. So knee car depine is used for urgencies. Knee car depine, knee car, 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 knee car depine is used for urgencies and emergencies. Are we clear? Yes or no? Next one. Non-dihydropyridines are used for verapamil and diltiazem. They're used for hypertension. How in hypertension will they decrease will they decrease the force of contraction? The answer is yes. In angina, will they decrease the force of contraction and cause decreased workload? The answer is yes. In atrial fibrillation and flutter, do you guys remember yesterday I told you that at atrial fibrillation, is there more chance for having an emboli? Yes or no? In atrial fibrillation, is there more chance of having an emboli? The answer is yes. So Okay, you guys can hear my voice, right? Yes or no? Yes. Okay. So what was I talking about? I was talking about, let's say this is the heart, right? Over here, if we have cholesterol deposition, right, in the atrium, if we have cholesterol deposition in the atrium, if there is excessive contraction of the atrium, is there a possibility that the cholesterol can break off and lodge into the systemic circulation? The answer is yes. So should we give a drug that prevents excessive contraction? The answer is yes. So calcium channel blockers, they are used for atrial fibrillation. Okay, are we clear? Adverse effects. What are the adverse effects? Very important. They can cause gingival hyperplasia. That's very important. Dihydropyridines. Do you guys realize that calcium channel blockers, they can cause swelling of the feet? Yes or no? Angioedema. Yes. Okay, they can cause swelling of the feet and angioedema. So that's that. So they can cause peripheral edema, flushing, dizziness sometimes. So out of all of this, peripheral edema is one of the most highest yields. Okay, peripheral edema is the highest yield. Non-dihydropyridine, they can cause cardiac depression, atrioventricular block. This is very important. And they can cause constipation. Can anyone tell me how do they cause constipation? Dr. Ethar, do you have any idea? How do they cause constipation? How do they cause constipation, calcium channel blockers? Can you guys hear my voice? Yes or no? Okay. If there is decreased peristalsis, will there be increased constipation? Yes or no? The answer is yes. So do we need calcium for contraction? Wait, number one question. The GIT, are they smooth muscles or skeletal muscles? Fast answers, please. Smooth muscles. For smooth muscle contraction, do we need calcium? The answer is yes. If we block the calcium, will there be increased contraction or relaxation? Relaxation. As a result, will there be more peristalsis or less peristalsis? Less peristalsis. Okay, so we will have more constipation. Next one, hydralazine. Okay, hydralazine is a group of drug that increases your CGMP activity. What happens when we increase CGMP activity? When we activate CGMP, do we have the activity of myosin light chain phosphatase? Yes or no? The answer is yes. Do we have vasodilatation or do we have dilatation or contraction? We have dilatation. Yes. So they cause CGMP, that is smooth muscle relaxation. So we have vasodilatation. Hydralazine, they have two A's for arteries. That is, they work more on arterioles than they does on the veins. If they work on the arteries, can they also work on the ascending aorta, which is also an artery, of course? Yes or no? The answer is yes. As a result, will there be relaxation of the aorta or contraction of the aorta? The answer is there is relaxation of the aorta. As a result, will afterload increase or will afterload decrease? The answer is afterload will decrease. Okay, that's that. Where do we use hydralazine? We use hydralazine in pregnancy. Okay, we use hydralazine in pregnancy. Next one, if there is relaxation of the ascending aorta, will more blood reach the carotid sinus and the aortic receptors? Yes or no? The answer is yes. Yes, if the ascending aortas are relaxed, will more blood come out from the left ventricle to the out? Yes or no? The answer is yes. When it comes out, will it cause more stretching of the aortic and carotid sinus receptors? Yes or no? Baroreceptors? The answer is yes or no? Okay. Yes. So over here, if there is increased amount of blood that's basically coming out, right? That's basically coming out. They can cause more activity of the aortic receptors and the baroreceptors, and initially the patient can experience a state of parasympathetic innervation. But right now, over time, when there is the ascending aorta, when it's relaxed for a long period of time, at one point, will less blood come out from the left ventricle out to the aorta because of loss of vascular tone? Yes or no? The answer is yes. And in right now, when the vascular tone is decreased and less blood is coming out, will there be more stretching of the aortic receptors in the carotid sinus later? Yes or no? The answer is yes. So will there be excessive sympathetic or parasympathetic activity? Less stretching, less. There will be less stretching of the aortic and carotid sinus in the late phase. In the early phase, more blood will come out. So patients can experience a parasympathetic innervation, but over time, due to loss of vascular tone, less blood will start coming out, and this will result in less stretching of the aortic and carotid sinus receptors. As a result, patients can get sympathetic innervation and they can get reflex tachycardia. Are we clear? Yes or no? They can get reflex tachycardia. Which drug do we give to prevent reflex tachycardia with hydralazine? This is beta blocker. Very high yield. Okay. Are we clear, everyone? This is a very important question in your USMLE step 1. They want to know whether you have the knowledge that beta blocker is given with hydralazine, and if it is, then why? Okay. Next one, adverse effects. Adverse effects is they can cause tachycardia, fluid retention, headache, angina, and drug-induced lupus. Now, headache. If there is dilatations of the cerebral blood vessels, will there be headache? Yes. Angina. How do they cause angina? If there is dilatation, can we have coronary steal syndrome? For example, let's say there is a blocked vessel in the heart and there's an unblocked vessel in the heart. When there is vasodilatation, the unblocked vessel will dilate and all the blood will start going through the unblocked vessel. So should there be further ischemia of the blocked vessel? Yes or no? The answer is yes. What is the name of this syndrome? This is called coronary steal syndrome. Yes. So can hydralazine cause coronary steal syndrome? The answer is yes. Okay. Then they're also known for causing drug-induced lupus. So this is very high yield. I'll talk about this later in rheumatology, and that's that. Next one, in hypertensive emergencies, right? In hypertensive emergencies, this is not very high yield. So I'm going to use my blue pen for this. In hypertensive emergencies, we use nicardipine. Do you guys remember when there's an emergency, do we walk or do we use a car? The answer is we use a car. So the answer is nicardipine over here. If you can remember nicardipine, then that's very good. Then let's move forward. We also would like to use sodium nitroprusside and phenol-dopam. Sodium nitroprusside is more important than phenol-dopam. Okay. So this is a short-acting vasodilator that increases CGMP. Once again, if CGMP is activated, Dr. Otero. If CGMP is activated, which enzyme is activated? Myosin light-chain phosphatase or myosin light-chain kinase? Which one? Dr. Otero. Phosphatase, very good. So CGMP activation results in phospho. Will there be more relaxation or less relaxation? The answer is there will be more relaxation. But the number one side effect of using sodium nitroprusside is they can cause severe cyanide toxicity. Severe cyanide toxicity. Are we clear? Yes or no? Next one, phenol-dopam. This is a dopamine receptor agonist. So dopamine receptor agonists, they are known for their vasodilatory actions, right? Dopamine receptor agonists, they are known for their vasodilatory actions. They bind to the D1 receptor. And when they bind to the D1 receptor, they can cause splanchnic vasodilatation. It's not very high yield, but you can try to remember this. So dopamine D1 receptors, they can cause vasodilatation. This is not very widely asked, so you do not have to put a lot of attention to phenol-dopam, but nitroprusside is very important. They work by the same way. Phenol-dopam, they cause vasodilatation. Let's move forward to the next one, nitrates. Nitrates are, do you think that nitrates are important for your exam? Yes or no? Nitrates are very important. Okay, nitrates, we have nitroglycerin, isosorbide, dinitrate, and mononitrate. Isosorbide, dinitrate, and mononitrate. How do they work? Basically, nitrates, for example, can nitrates be converted to nitric oxide? Yes or no? Can nitrates be converted to nitric oxide? The answer is yes. When nitrates are converted to nitric oxide, this nitric oxide, will it cause more cGMP activity? Yes or no? The answer is yes. As a result, will there be more action of the myosin light chain phosphatase? The answer is yes. So will they cause vasodilatation or vasoconstriction? The answer is they'll cause vasodilatation. So vasodilatation by increasing nitric oxide. As a result, cGMP increases and smooth muscle is relaxed. So over here, if the smooth muscles are relaxed, do we have loss of vascular tone? The answer is yes. As a result, will more blood go back to the heart or less blood go back to the heart? The answer is less blood will go back to the heart. Will it decrease the preload or increase the preload? The answer is it will decrease the preload. Okay, let's move forward. Clinical use, it's used for angina, acute coronary syndromes, and pulmonary edema, very high yield. Now, the adverse effects of nitrates are the same. The same way, if the preload is decreased, will less blood flow out of the heart? Yes or no? The answer is yes. As a result, will there be less stretching of the receptors, baroreceptors? Yes or no? If less blood comes out? The answer is yes. So will there be more sympathetic activity or less sympathetic activity? More sympathetic activity. So just as how we had reflex tachycardia in hydralazine, can nitrates also cause reflex tachycardia? The answer is yes. So we should also treat nitrates with beta blockers. Okay. Then they can also cause hypotension, flushing, and headache. Another thing is there's this disease called Monday disease, right? What is Monday disease? Monday disease is that over here, what happens is when we have industrial workers, right? Industrial workers over here in the US, we work from Monday to Friday, right? So when industrial workers, they have been exposed to nitrates for such a long period of time, right? That they start developing tolerance for the nitrates. Are we clear? They start developing tolerance for the nitrate. Let me explain what this is. Just give me 1 second. Okay, give me 1 second. Okay, now let's say that this is the industry. Okay, this is the industry, right? And this is your worker. When workers, they go to the industry, they are exposed to a lot of nitric oxide. Okay, all this nitric oxide that they're exposed to the nitric oxide from Monday to Friday, right? From Monday to Friday. But when they are exposed to Monday to Friday nitric oxide, more or less throughout the entire year, can they develop tolerance to nitric oxide? Yes or no? The answer is yes. Now, from Friday to Sunday, do they stay home or do they go to the industry? The answer is they stay home. When they stay home, are they exposed to nitric oxide? Yes or no? The answer is no. As a result, do they have decreased tolerance of nitric oxide in the weekend? Does the tolerance decrease in the weekend? The answer is yes. So after this, when they go back to work again on Monday, are they exposed to nitric oxide very newly? Yes or no? New exposure? The answer is yes. So should there be a sudden overactivity of nitric oxide? The answer is yes. So patients, can they have excessive vasodilatation due to nitric oxide re-exposure? The answer is yes. So can they have flushing, reflex tachycardia, headache, dizziness, and all of these things? The answer is yes. What is the name of this disease? This is called Monday disease for industrial workers. Are we clear? Yes or no? Okay. This is Monday disease. This is very important. Very important. Next one. Your CGMP is broken down by which enzyme? CGMP is broken down by phosphodiesterase 5, right? Yes or no? So if we give nitric oxide or nitrates, and we also gave a phosphodiesterase 5 inhibitor at the same time, we give these two drugs at the same time, can there be excessive amount of CGMP due to increased formation and decreased breakdown? The answer is yes. So can we get life-threatening vasodilatation and severe hypotension? Yes. So should we give phosphodiesterase 5 inhibitor and nitrates together? Yes or no? The answer is absolutely not. Okay. What is a potent phosphodiesterase 5 inhibitor? Have you guys ever heard of drugs that are used in Viagra's? Yes or no? Sildenafil, right? Sildenafil. Sildenafil is used for sexual impotence. Okay, sildenafil is used for sexual impotence, and the way that sildenafil work is that they cause inhibition of phosphodiesterase 5, so there's increased penile blood flow. As a result, they have reversal of impotence. But if there is a patient who has impotence and the patient also has acute coronary syndrome, is nitric oxide a good choice of drug for those patients? The answer is absolutely not, because there can be severe vasodilatation. So is it absolutely important to take a history before we give nitrates to the patients? The answer is yes. Okay. That's contraindicated also in right ventricular infarction. Why? In right ventricular infarction, do we need more blood in the body or less blood in the body? The answer is we need more blood in the body to cause stretching. Is that why we give IV fluid to right ventricular failure? The answer is yes. Okay. Also, in hypertrophic cardiomyopathy, do we want more blood in the body or less blood in the body? We want more blood in the body, because the more blood there is, the less obstruction there is. So that's that. Okay. So do not use these drugs in these conditions. Okay. Are we clear? Let's move on to the next one. Let's move on to anti-anginal therapy. Are you guys understanding the lecture? Yes or no? Yes. Okay, so let me ask you something. Feedbacks from my students are very important to me. This allows me to restructure my lecture according to the needs of the students. So if you guys wouldn't mind, can I get some quick feedbacks on the pace of the lecture? Is it good or not? Or is it okay? Should I increase the pace, or should I decrease the pace, or should I go at the same pace? Same pace. Okay. Next one is, are you guys understanding my voice? Hearing the voice? Yes. Are you guys clear with the concepts? Are you guys able to solve questions more easily? Yes. Okay, good. So very good. So how about this? Since we started the class today at 9:30, it's already close to 12. Can we take a short break before we begin with these pages? Yes. Okay. So let's take a short break. And can I get the attention of Dr. Can I get the attention of Dr. Sri Priya Anumola? Dr. Sri Priya, can you hear my voice? Yes, okay. Please check your email for, we will be sending you an email very shortly. Please check and try to get back to us as soon as possible. Okay, so thank you so much. Let's take a break for 15 minutes and let's come back. Okay, thank you so much. Okay, can I get the attention of Dr. Sri Priya very quickly? What is your email address, please? Can you send us your email address? Okay. Thank you so much. Please check your email and get back to us as soon as possible. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Is everyone back from their break? Can you guys hear my voice? No. So let's begin with the lecture over here. So we were talking about calcium channel blockers, hydrelazine, and everything else. Now let's start talking from anti-anginal drugs. Are we ready? One more time. Can I get a yes or a no? Okay, let's begin. Anti-anginal therapy. What is the goal for anti-anginal therapy? The goal of anti-anginal therapy is decreasing one or more of the determinants of oxygen consumption, meaning that we have to decrease one or more of the factors that are responsible for increased oxygen consumption. So if we decrease the workload of the heart, will it decrease oxygen consumption? Yes or no? The answer is yes. If we decrease the heart rate, will it decrease oxygen consumption? The answer is yes. If we decrease preload, will it decrease the workload of the heart? Yes. Will that decrease oxygen consumption? The answer is yes. Okay. So these are the components of oxygen consumption, right? So this is just for your understanding purposes. Nitrates. Okay, let me see if you guys can answer me this without saying anything else. Okay. Now nitrates over here. Okay. Will nitrates in diastolic volume? Then what are some components? Blood pressure is a component, right? Blood pressure, heart rate is a component, contractility is a component. Then what else? Ejection fraction is a component, and oxygen consumption is a component. Okay, now nitrates, will that decrease or increase end diastolic volume? Fast answers, please. Decrease. Will it decrease blood pressure? Decrease. Now, nitrates, can they cause reflex tachycardia and reflex contraction? Yes. So heart rate, can it increase in the absence of beta blockers? The answer is yes. Contraction, can it increase? Yes. Okay. But due to the drug itself, okay, not ejection fraction, ejection time. When we give nitrates, the heart is basically going to have decreased workload, right? So when the workload is decreased, oxygen consumption is increased or decreased? Oxygen consumption is increased or decreased? Decreased. Very good. Do we have more time for the blood to leave the heart? Yes or no? When the blood pressure is low and diastolic volume is low, the answer is yes. So ejection time is over here is initially it should be high, but then again, once due to the action of the sympathetic activity due to reflex tachycardia, once we give nitrates, we have reflex tachycardia. And in reflex tachycardia, do we have more time for the blood to leave or less time? The answer is we have less time, because in sympathetic activity, the heart rate is increased. Due to the increased heart rate, the time needed to leave the time needed for the blood to leave the heart is decreased. So that's it. Okay, now let's talk about beta blockers very quickly. Beta blockers, will it increase or decrease end diastolic volume? Over here, beta blocker has no function on end diastolic volume as much. Blood pressure, will it be decreased by beta blocker? Yes or no? The answer is yes. Heart rate, will it decrease? Yes. Contractility, will it decrease? Yes. Will we have more time for the blood to leave? The answer is yes. Oxygen consumption, will it decrease? The answer is oxygen consumption will decrease. Okay. Are we clear? Yes or no? Okay. Now, if we give beta blocker and nitrates together, what will happen? Beta blocker and nitrates, if we give it together, then what will happen? One decreases, one has no effect. So overall, it could decrease. Blood pressure, will it decrease or increase when we give nitrates and beta blocker together? Blood pressure will decrease. Heart rate, one tries to increase, one tries to decrease the heart rate. So heart rate, will it be instead of high, can it be normal? Where when we use it together, nitrate and beta blocker together, the answer is yes. Contractility, will it be normal? One increases, one decreases. So they cancel each other out. That's normal. Ejection time, one decreases, one increases. Can this be normal? The answer is yes. Oxygen consumption, will it decrease? The answer is yes. Are we clear now? Yes or no? Everyone, are we clear? Yes? Okay. Next one is ranolazine. Okay. Ranolazine is another group of drug. Ranolazine is another group of drugs. They will inhibit the late phase of inward sodium current, thereby reducing diastolic tension and oxygen consumption. Now, ranolazine, they inhibit the late phase of sodium current. If they inhibit the sodium entry, ranolazine, in the myocardial action potential, right? In the myocardial action potential, if they inhibit the sodium entry, will there be slow depolarization? Yes or no? The answer is yes. Does it give enough time for the heart to fill up with blood if there is slow depolarization? The answer is yes or no. The answer is yes. So as a result, what will happen to oxygen consumption? Will it be high or will it be low? Oxygen consumption will be high or low? High. How is oxygen consumption high? If the myocardial action, if the myocardium has more time to fill with blood. Try to understand, please try to understand what I'm saying over here. In the myocardial action potential, if we give a drug that blocks sodium entry, will we have more time needed for depolarization? The answer is yes, we will need more time for depolarization. As a result, will the heart contract more or contract less? Answer me this first. The heart will contract less. If the heart contracts less, oxygen consumption is high or low? Low. Okay. Oxygen consumption is low for ranolazine. Remember there's a drug. Now, let me tell you how USMLE will use this drug. Are you guys aware that there are certain questions in USMLE that will set apart very good students from good students? Yes or no? Okay. That is, they will not test certain concepts for everyone. If you can answer certain questions, which is a indication that you understand the concepts more, then you will get a better mark. Ranolazine is that group of a drug. If you do not understand ranolazine, will you fail your exam? Yes or no? The answer is no. But if you understand ranolazine and you answer the difficult question, can you have higher scores? The answer is yes. So that's how ranolazine is important. Are we clear? Yes or no? So if you want to score very high and you want to keep in mind a lot of information, then please, I insist you guys to understand and remember the mechanism of action of ranolazine. That's that. Clinical use, it's used for refractory angina. What does this mean? Refractory angina means angina that is still present after the normal treatment. Okay, after you give the first line group of drugs, if they do not work, then you give ranolazine. Are we clear? Yes or no? Adverse effect wise, ranolazine can cause constipation. That's important. They can cause constipation. This is the only one you need to remember. Okay. Are we clear? Yes or no? Now, do you remember in physiology, I talked about this one hormone, ANP and BNP, that is released in heart failure that causes severe natriuresis and decreases blood volume in heart failure, yes or no? And do you remember I talked about one enzyme called neprilysin, which breaks down BNP and ANP. ANP and BNP, they are broken down by an enzyme called neprilysin. In heart failure, do we need more ANP and BNP or less ANP and BNP? Fast answers, please. More. So should we use a drug that inhibits neprilysin? The answer is yes. What is the name of the drug that inhibits neprilysin? The name of the drug is sacubitril. High yield. Once again, important for getting very good scores. It's a very good score type of a question. Okay. It's used in combination with ARB. ARBs, they also decrease blood volume to treat heart failure. Okay. Are we clear? Adverse effect wise, they can cause hyperkalemia, that is high yield, and they can cause cough. And since they cause dry cough, should we use sacubitril with ACE inhibitors or with ARB? Fast answers, please. Since they cause dry cough, should we use it with ACE or ARB? The answer is we should use it with ARB inhibitor. Okay. Are we clear, everyone? Yes or no? Next, so we are done with drugs that are used for cardiovascular conditions. For the next couple of minutes, we will talk about drugs that will decrease your lipid. Are we ready? Yes or no? Okay. So the first group of drug that I want to talk about that will decrease your lipid is HMG-CoA reductase inhibitor. Now, what is HMG-CoA reductase? Let's have a look at the pathway. This is the mevalonate or the biochemical pathway for the synthesis of cholesterols. Okay. For the synthesis of cholesterol, cholesterol is synthesized from acetyl-CoA. Acetyl-CoA is converted to acetoacetyl-CoA. Acetoacetyl-CoA is converted to mevalonate by HMG-CoA. This is the rate limiting step. And as you can see, mevalonate is ultimately converted to cholesterol. So if you block HMG-CoA, will we have mevalonate? Yes or no? Will we get mevalonate? The answer is no. If we do not get mevalonate, do we get the formation of cholesterol? Yes or no? The answer is no. Yes or no? Fast answers, please. No. Okay. Now, did we understand the mechanism of action of HMG-CoA? I think we did, right? So we understood the mechanism of HMG-CoA. What is the adverse effect of HMG-CoA inhibitor? Number one, H for hepatotoxicity. M for myopathy, not myositis. Myositis is inflammation of the muscles. Myopathy is a pathology of the muscle. That's the different thing. One is an inflammation, one is pathology. Over here, myopathy basically means that patients have muscle pain, not muscle inflammation. And hepatitis means inflammation of the hepatic parenchyma. Hepatotoxicity means accumulation of toxic substance in the hepatocytes. Both are different. So hepatotoxicity and myopathy. Are we clear, like everyone? Yes or no? Okay. Next one is another group of drugs that can also cause myopathy. I'll talk about this. 1 second. There's another group of drug that is, we call this fibrates. Okay. Now, fibrates, the way that they work is that over here, in order for you to understand this, give me 1 second. I'll talk about this over here very quickly. I'll talk about this structure over here very quickly. Give me 1 second. Before you understand how fibrates work, you need to understand the lipid lowering pathways. Okay. Now, do I have everyone's attention? Okay. Give me 1 second. Today's class is a very important class. All the students who are listening to the recording, please try to understand the concepts. If you do not understand the concepts, please make sure that you come to the class and ask us questions if you have any. Okay, 1 second. Okay. So we have 3 compartments. Okay, so we have 3 compartments. Number 1, this purple compartment over here is your liver. This compartment over here is your blood vessel. Okay, and this compartment over here is your intestines. In the intestines, you have these type of cells. these type of cells. These cells are enterocytes. These are enterocytes, and this is your intestinal lumen. Okay. Now let's talk about the normal physiology. Then we'll talk about the drugs. Are we ready? Yes or no? Okay. Now let's start from the beginning. First, how many of us are aware that when we have excessive rice and carbohydrate and we are not using that carbohydrate, they can be converted to cholesterol and fat? Are you guys aware of this, right? Yes or no? And please have fast answers because I want to finish this. The answer is yes. Now, carbohydrate via the process of glycolysis, is it broken down to form acetyl-CoA? Yes or no? By pyruvate dehydrogenase complex? Yes. So that acetyl-CoA, if we use the acetyl-CoA for exercise or movement or anything else, will they be converted to ATP in the TCA cycle? Fast answers, please. The answer is yes. But if we have carbohydrate and we do not exercise or move around, is there a possibility that that acetyl-CoA will be present in the liver to get converted to cholesterol? Yes or no? The answer is yes. So acetyl-CoA is converted to HMG-CoA, and HMG-CoA is converted to what? Cholesterol via mevalonate and all of the pathway, and ultimately we have the formation of cholesterol. Now, the next one is this cholesterol, will it stay in the liver or will it get released from the liver into the blood vessel? Fast answers, please. This will get released, right? Cholesterol is released from the liver by the form of very low density lipoprotein. Because cholesterol, can it travel in the blood by itself, or does it need the help of a plasma of a lipoprotein? The answer is it cannot travel by itself. It needs the help of a lipoprotein. So cholesterol will be converted to a very low density lipoprotein. This very low density lipoprotein will get released into the blood vessel. This will get released into the blood vessel. After they are released into the blood vessel, then what happens? After they're released into the blood vessel, this very low density lipoprotein, can it go to different organisms and can it deposit over there? First question, the answer is yes. Next one is very low density lipoprotein will be converted to low density lipoprotein. Yes or no? Fast answers, please. Yes. Yes, they are converted to low density lipoprotein, and they are also converted to what? They're also converted to fat. How? How are they converted to fat? They're converted to fat by the action of lipoprotein lipase. To be completely accurate, it's fat. It's a free fatty acid, not fat. I'm saying fat because it's easy to remember. Okay. And this fat, where is this stored? This fat, this is stored in the adipose tissue. Okay. Now let's talk about the fate of the low density lipoprotein. This low density lipoprotein, will it come back from the blood and come to the liver? Yes or no? Because are we aware that low density lipoprotein is bad and HDL, high density lipoprotein, is good? Question is why? Low density lipoprotein is bad because it helps in the formation of more cholesterol. Okay, it helps in the formation of more cholesterol, and HDL takes cholesterol away from the blood vessel to the liver to get broken down. Yes, HDL breaks down cholesterol. Okay, so this LDL that is formed from the VLDL, will it get uptaken by the LDL receptor? Yes or no? They will get taken up by the LDL receptor. And once they are taken up, can they add to the cholesterol pool and increase the synthesis of more cholesterol? The answer is yes. Okay, so this is the normal physiology. Okay, this is the normal physiology. Now let's talk about another way. So we talked about how carbohydrate can be converted to acetyl-CoA, and that is converted to cholesterol and this pathway. But are we also having fat in our diet? Yes or no? Fatty food in our diet? Yes or no? Right? How? For example, let's say that we have what? Can anyone tell me what this is? What is this? Pizzas, right? So this pizza, does it contain fat or not? Fast answer, please. Yes. When we have pizzas, which contains fat, are they broken down by the intestinal lipase? Right? This could be pancreatic lipase, intestinal lipase, right? Yes or no? And they're broken down to form what? Cholesterol, free fatty acids. Yes, in the intestinal lumen. Now, this cholesterol and free fatty acids, are they converted to micelles by bile acids? Yes or no? The answer is yes. When they're converted to micelles by bile acid, can they be absorbed by the enterocytes more easily? The answer is yes, because they decrease the surface tension. So cholesterols, they are absorbed via the intestines. The cholesterol and the free fatty acid, they are absorbed and they are converted to another lipoprotein-like structure. We call this as chylomicrons. Are we clear? They're converted to chylomicrons. Okay. Now, this chylomicron, will they be absorbed from the intestinal lumen and the enterocytes into the blood vessel? Yes or no? The answer is yes or no. Fast answers, please. I need some feedbacks from you guys. Yes, via the lymphatics. They will get absorbed into the blood vessel via the lymphatics. Okay, are we clear? But will they come to the blood vessel or not? Yes or no? That's the question. Okay, good. So they can come to the blood vessel via the lymphatics, but that's not the goal. The goal is that they come to the blood vessel. That's the main point. Then the chylomicron over here, can they be also converted to fat? Yes or no? By lipoprotein lipase, the same enzyme? Yes. The answer is yes. And chylomicrons, can they also be absorbed by the liver by chylomicron receptors? Yes or no? The answer is yes. And this chylomicron, can it help form more cholesterol? The answer is yes. Okay. And some of the chylomicrons will be converted to HDL. Some of the chylomicron will be converted to HDL. They will be converted to HDL. And this HDL, what will they do? This HDL, will they be also taken up by the liver? The answer is yes. Yes or no? Yes, now okay, good. So what will this HDL do? This HDL will be taken up by the liver too. And we told you that HDL is a good lipoprotein, right? HDL, what will they do? When they are taken up by the liver, HDL will immediately break down cholesterol to form more VLDL so that the VLDL can be converted to free fatty acids and they can be removed from the blood vessel. So that's why HDL, does it allow a lot of VLDL to remain in the blood vessel or less VLDL to remain in the blood vessel? The answer is HDL allows less VLDL to present in the blood vessel because they are converting the VLDL to fat as fast as possible. That's why HDL, do they promote atherosclerosis or decrease atherosclerosis? The answer is HDL, they decrease atherosclerosis. Okay. Are we clear, everyone? Yes or no? Okay. So the fact that VLDL and LD and chylomicrons, they are converted to free fatty acids and adipose tissues, and they're removed from the blood vessel by the lipoprotein lipase. Is that a good activity or a bad activity? Fast answers, please. That's not a bad activity. That's a good activity because they are removing the cholesterols from the blood vessels. We do not want cholesterols to be in the blood vessels. We want the cholesterols to get stored in fat in adipose tissues. If they are in the blood vessels, they will cause blood vessel blocking. So lipoprotein lipase is removing these cholesterols from the blood vessels into the fat. So are they good or are they bad? The answer is they are good. Okay. Are we clear, everyone? Yes or no? So if we give a drug, okay, if we give a drug that increases the activity of lipoprotein lipase, will the cholesterols be removed from the blood vessels fast? Yes or no? The answer is yes. What is the name of the drug? The answer is, the name of the drug is fibrates. Fibrates, the mechanism of action is that they increase lipoprotein lipase activity and they remove cholesterol from the blood vessels. Are we clear, everyone? Yes or no? Yes? Okay, good. They also have a secondary mechanism of action. The secondary mechanism of action is that they increase the activity of an enzyme called peroxisome proliferating activating receptor alpha, not gamma, alpha. And this increases more HDL synthesis. So two ways. Are we clear, everyone? Yes or no? Okay. Okay. There is another third function that is very important for USMLE. There's another third function that is very important for USMLE. That is, they inhibit an enzyme called cholesterol 7 alpha hydroxylase. Cholesterol 7 alpha hydroxylase breaks down cholesterol. So if they inhibit this cholesterol 7 alpha hydroxylase, can more cholesterol accumulate in the tissues, not the blood vessel, the tissues, especially the gallbladder? Yes or no? Right? So can we get cholesterol gallstones with fibrates? Yes. So this mechanism of fibrate is responsible for the adverse effect. So what are the adverse effects of fibrates? Number one, fibrates can also cause myopathy and they can cause cholesterol gallstones. Are we clear, everyone? Yes or no? Okay. Okay, good. Next one. Let's come over here. Do you guys remember over here, I told you that cholesterol and free fatty acids, they're converted to micelles by bile acid? Yes. If we give a drug that inhibits bile acid to convert these things into micelles, will there be more absorption or less absorption? there will be less absorption. So the cholesterol in the blood vessel, will it be high or will it be low? It will be low. Very good. What are the names of these drugs that inhibits bile acids? They are called bile acid binding resins. That is cholestyramine, cholesterol. So if these bile acid binding resins, if they are preventing the cholesterol to get absorbed, do we have more cholesterol and free fatty acid in the lumen of the intestines? Yes or no? The answer is yes or no. Can you guys hear my voice? If bile acid binding resins are preventing the absorption of cholesterol and free fatty acids into the enterocytes, do we have more cholesterol and free fatty acids in the lumen? Yes or no? The answer is yes. As a result, can we have osmotic diarrhea? Thank you so much for your answers. Really appreciate your fast response. Okay, let's move forward to the next one. That if I give another drug that inhibits this absorption, that is, the bile acid is there, everything is there, micelle is formed. Even after micelle is formed, are they absorbed by the enterocytes? Yes or no? The answer is yes. Right? After we have formation of micelles, are they absorbed by the enterocytes? The answer is yes. But if we block the absorption of the micelles and the enterocytes, can we prevent the cholesterol to come to the blood? Yes or no? The answer is yes. What is the name of that group of drug that prevents cholesterol absorption at the brush border of intestines? The name of that drug is, thank you so much, that's ezetimibe. Ezetimibe. Are we clear? Yes or no? Okay. So very quickly, one more thing before I move forward. That is, there is another group of drugs. Okay. There is another group of drug that does something. Let me tell you what it does. This group of drugs, what it does is they inhibit cholesterol to get converted to VLDL. Let me use my green pen for this. These group of drugs, they inhibit cholesterol to get converted to VLDL. As a result, if cholesterol is not converted to VLDL, obviously they will not be present in the blood vessel. Yes or no? The answer is yes. So does anyone know the name of the drug that prevents cholesterol to get converted to VLDL? The name of that drug is niacin. Okay, niacin is basically a drug that inhibits cholesterol conversion to VLDL, B3, yes. But niacin also has the tendency of causing some adverse effects. I'll talk about this very quickly. Last group of drug that I want to talk about is there's another group of drug that will inactivate the receptors. Okay, that will, let me tell you. Do you know these receptors, LDL receptors, then VLDL receptors, right? VLDL, LDL receptors. Are they important for the uptake of cholesterol from the blood to the liver? Yes or no? Are they important? Yes or no? Yes. Okay. So if these receptors are functioning properly, will the cholesterol leave the blood vessel and enter the liver? Yes or no? The answer is yes. Our goal for lipid-lowering agents are, what is our goal? Our goal for giving lipid-lowering drugs is to decrease fat in blood vessels. So anything that will decrease the fat in blood vessel is important for lipid-lowering. So LDL receptors are a very important receptor for removing the fat in the form of LDL from the blood vessels. But there is an enzyme that breaks down LDL receptor. The name of that enzyme is PCSK9 enzyme. PCSK9. So if these receptors are broken down by these enzymes, will more fat stay in the blood? Yes or no? The answer is yes. But can I give a drug that inhibits this enzyme? Can I give a drug that inhibits this enzyme? The answer is yes. If this enzyme is inhibited, will there be more LDL receptor or less LDL receptor? Very good, more LDL receptor. If there's more LDL receptor, will more fat get removed from the blood vessel? The answer is yes. Okay, so now finally, let's talk about the lipid lowering agents one more time. Okay, one more time. First and foremost, the number one choice of drugs for lipid lowering agent is HMG-CoA inhibitor. This is the mechanism of action. What is the name of the drug? This is statin. Okay, next one. Increase lipoprotein lipase activity. What is the name of this drug? Fast answers, please. This is fibrates. Next one. Decrease bile acid. As a result, decrease intestinal absorption. Intestinal absorption. What is the name of this drug? Cholestyramine. 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 Number 4, another group of drug that decreases brush border absorption in the intestines. Well, what is the name of this drug? Ezetimibe. Next one. A drug that inhibits cholesterol to get converted to VLDL. This is niacin. Next one. Drug that decreases LDL receptor breakdown. This is a PCSK9 inhibitor, or we call this drug as alirocumab. It's a monoclonal antibody, MAB, M-A-B for monoclonal antibody, alirocumab and evolocumab, evolocumab. Are we clear? Yes or no? Okay, next. Next is, what are the adverse effects? Number 1 is we have a drug that causes hepatotoxicity. We have a drug that causes hepatotoxicity and myopathy. This is statin. Next one, we have another drug that causes increased osmotic diarrhea and GI upset. This is bile acid resins, cholestyramine, cholesterol. Next one, we have another drug that can also cause diarrhea. This is ezetimibe. Next, we have another drug that can cause myopathy only. This is fibrates. So can we give fibrates and statin together? Yes or no? Absolutely not. They will cause myopathy. Okay. Next one, we have another drug that can cause flushing, hyperglycemia, hyperuricemia. This is niacin. Very good. Okay. Next one, we have another drug that can cause CNS dysfunction. This is PCSK9 inhibitor. Okay. Are we clear? Now, over here, ezetimibe has another adverse effect. Please try to remember this. They can increase your liver function test. It's not high yield. That's why I did not mention this. It's pretty rare. Another adverse effect of fibrates are that they can cause cholesterol gallstones. And with that, we are done with lipid-lowering agents. Are we clear, everyone? Yes or no? Okay. Okay, good. We have another drug over here. These are fish oil. Fish oils, they are used as a daily dietary supplement. They are believed to decrease free fatty acid and decrease activity of triglyceride enzyme. They are not high yield, so don't worry. You will not get any questions or many questions from over here. Now, let's talk about this table over here. HMG-CoA reductase inhibitor. You have to remember that they decrease LDL and they increase HDL. Over here, you need to remember niacin. Niacin will increase HDL, decrease LDL. Same thing over here. Okay. Then the next thing, if you want to remember anything else, try to remember fibrates. Okay. Now, the easiest way you can remember is what are the three. Okay, let me tell you this. This is how you remember. What are the three lipid-lowering agents that will decrease LDL mostly? The answer is number 1, statin. Number 2, niacin. Number 3, PCSK9. Next question for Usmle is, which group of drug will decrease triglyceride the most? Not LDL, triglyceride. The answer is only one, fibrates. If you remember this information, then you do not need to remember the table over here. Okay, and everything else except this portion, this one, and the names, of course, are extremely high yield for your exam. Are we clear, everyone? Yes or no? We're done talking about this too. This is also high yield for physiology, for understanding purposes. You will not get any questions from over here. Okay, can you guys hear my sound? Hear the voice? Is the voice clear? Clear. Okay, good. Now, we are going to start talking about cardiac glycosides. Before I start talking about cardiac glycoside, can I ask you guys to read this table one more time? I can ask you questions and then I'll move forward. How long do you guys need to read this table for once? 5 minutes or 10 minutes? Can you show the picture you made? Yes. Instead of looking at my picture, look at this picture, please. Okay. This one. Instead of looking at this picture, try to look at this picture. Okay. So can I give you guys 5 minutes to read the lipid-lowering agent table? Okay. After that, I'll ask you questions and then I'll move forward. Okay, is everyone done? Yes or no? Can you guys hear my voice? Is everyone done? Yes. Okay, good. Okay, so quick question, quick answers, please. What is the name of the drug that can cause hepatotoxicity and myopathy together? Fast answers, please. Statins. Name of the drug that can cause diarrhea and increase or liver function test rarely. Fast answers, please. Ezetimibe. Very good. Name of the drug that can cause myopathy and cholesterol gallstones. Fibrates. Name of the drug that can cause flushing, hyperglycemia, hyperuricemia. Very good. Name of the drug that can cause CNS manifestations. Yes. Okay, good. Next one is cardiac glycosides. Do you guys know how cardiac glycosides work? Did I talk about this before? Yes or no? Did I talk about cardiac glycosides before once? Let me talk about this one more time. Let me talk about this one more time. Cardiac glycosides. Now, are we ready? Yes or no? Cardiac glycosides basically this is basically a myocyte. Okay, this is a myocyte, meaning that a heart muscle cell. In a heart muscle cell, we have two types of channels. Number one, we have a sodium calcium exchanger, and we have a sodium potassium ATPase. Sodium calcium exchanger, and then we have a sodium potassium ATPase. So how is the sodium calcium exchanger working? The sodium calcium exchanger works by getting rid of calcium, by taking the calcium out and bringing the sodium in. Are we clear? How does sodium potassium work? They take the sodium out and they bring the potassium in. They bring the potassium in. This calcium, this one, the one that's being released from the cell, where is this calcium coming from? This calcium is coming from sarcoplasmic reticulum. This calcium is released from the sarcoplasmic reticulum, right? Now, if I block this channel, the sodium potassium ATPase, if I block this channel, will sodium leave the cell? The answer is no. Will there be increased sodium inside the cell? The answer is yes. So does more sodium come in the cell from outside to inside? The answer is no. So will calcium leave the cell for sodium to enter? The answer is no. As a result, can this calcium cause increased contraction of the cardiac muscle? The answer is yes. Okay. What is the name of the drug that inhibits sodium potassium pump? It inhibits the pump over here. This is digoxin. Okay. This is digoxin. Are we clear? Yes or no? Now, did we understand the mechanism of action of digoxin? Yes or no? The answer is yes. What is the use, or where do we use digoxin? Where do we use digoxin? Heart failure. We use digoxin for heart failure. Can we use digoxin for atrial fibrillation? The answer is yes. How? In atrial fibrillation, they decrease the AV conduction, AV node conduction. The AV node conduction is also dependent on sodium levels, yes or no? The answer is yes. So if they prevent the sodium from getting out, they prevent depolarization, and then they decrease the AV node conduction. Okay. Next one, adverse effect. Adverse effect for digoxin, one of the most highest yield one is for step one, always remember, digoxin causes blue vision. Very important. Digoxin causes blue vision. Okay. Do you guys want to see? Do you guys want to see this one thing? Let me show you. Just give me 1 second. Okay, there's no video for this. My apologies. But always remember this: digoxin, they will cause a blue-yellow vision. This is a bluish yellow. I wish I could show you. Just give me 1 second. Let me see. How does this look like? Blue, yellow vision, digoxin. Okay. Do you guys know the name of the painter who painted this thing over here? This is called what? The name of the painter is Vincent van Gogh. Yes or no? Have you guys ever heard of Vincent van Gogh? Yes. Okay. Vincent van Gogh always, more or less, in most of his pictures, he uses blue and yellow. This is the exact way how patients of digoxin toxicity they view the world. Have I made myself clear? Yes or no? Yes. Okay. Good. Now, what are some other adverse effects of digoxin? Some other adverse effects of digoxin are that they can cause severe, 1 second. That they can cause severe hyperkalemia. Okay. If there is hyperkalemia, why will there be hyperkalemia? There will be hyperkalemia because potassium is not being able to enter the cell. As a result, they'll remain inside the blood, and that can increase the potassium level. And if there is a patient who has hyperkalemia with digoxin, then that's a very bad prognosis. Have I made myself clear? Yes or no? What is in digoxin toxicity, right? In digoxin toxicity, what is the name of the antidote that we use? It's called anti-digoxin fab. Okay, anti-digoxin fab. Are we clear? Yes or no? Do we also have to give drugs that decreases the potassium in digoxin toxicity? The answer is yes. Okay. Are we clear, everyone? Yes or no? Yes. Okay. Okay, that's that. So we are going to keep the lecture up to here for today. Tomorrow we will finish the CVS pharmacology, and we will finish anti-arrhythmic drugs. I personally do not want to start anti-arrhythmic drugs right now because it's a lot of understanding, and I believe you guys will be overwhelmed with the information. So I'm going to keep it for tomorrow. Neurotransmitters are depleted, yes. Okay. So tomorrow we have a short class of first aid. So this gives us time for the best thing in our class. That is, does anyone know where I'm going with this? Since tomorrow we have a short lecture of anti-arrhythmic drugs. Yes, very good. Dr. Ithar, very good. Tomorrow is assessment test. Do you know what I call these type of assessment tests that come out of nowhere? I call them a surprise. Okay. So surprise, tomorrow you have your assessment test. Are we clear? Okay, so what will the test be on? Endocrinology and entire CVS. Are we clear? Tomorrow morning, if you guys are not here in the class by 9:30 a.m., if you guys are not in the class by 9:30 a.m., you will most probably miss the lecture of antiarrhythmic drugs. And trust me, you do not want to miss the lecture of antiarrhythmic drugs because antiarrhythmic drugs are very, very important. Once we finish antiarrhythmic drugs, we will start our exam most probably at 11:30. Okay. So tomorrow being in the class early in the morning, is it important or not important? Fast answers, please. Very important because we will be finishing antiarrhythmic drugs before we begin with the exam. So if you guys are not here at least by 9:40, I will wait for 10 minutes, and at exactly 9:40, I will begin my lecture for antiarrhythmic drugs. Please try to make sure you stay in the class in the early morning. Okay, have I made myself clear one more time? Can I get a yes or no in the chat box? Okay, so do you guys have a lot to revise today? Yes or no? Endocrine and CVS, do you guys have a lot to revise? Yes. Can anyone tell me what is the best way to revise endocrine and CVS? Do you guys have to go through first aid, or this? Do you know what the smart student will do? The smart student will solve questions from endocrine and CVS. Solve questions, UWorld questions. And if you have to go through something, go through the pharmacology portion, the drugs portion only, because the rest of the concept should be clear. Have I made myself clear? Yes or no? So once again, homework for today is prepare for tomorrow's exam. How long will be the exam for tomorrow? Does anyone have any idea? This will be a 1 hour exam, 40 questions. Okay, 40 questions, 1 hour. Are we clear? Yes or no? Yes. Okay. So with that being said, for today, I want to end the class here because I need to give you guys some time to prepare for the exam. So please start your preparation. Tomorrow is a very important day. We will finish antiarrhythmic drugs in the morning. Then we will begin with the exam at 11:30. Now, before I leave, does anyone else have any questions for me today? What is the next system? Most probably reproductive, but I still have not made up my mind. I'll let you guys know. Any other question? Does anyone have any other question? Yes or no, please? No. Okay, good. So thank you so much. Hope you guys have a great day. You guys are absolutely amazing students. I'm very proud of you guys. Please try to keep your concentrations and focus. And please make sure you are prepared for the exam for tomorrow. Okay. So with that being said, I wish you guys a very good luck and I wish you guys a very good day. If all is well, I'm going to take my leave right now. Okay. If you guys have any further questions, please send us an email. If you guys want to support our lectures, please visit our page over here. And if you guys want to support our lectures, please try to see if you can give us a review if you like our lectures or if there's any feedback. I'd really appreciate if you guys can give us a review. Thank you so much. I hope you guys have a great day. So bye-bye now.